I'm going to ask perhaps Bob to help us focus on a few actionable items that we might want to start thinking about to move this forward, because the idea, we hope, is between now and April 6, 2011, we can really have just move the needle forward a little bit in beginning to form a new community and new virtual institute in this space.
Well, we've pretty much tipped our hand in our latest RFP. I think much of what you heard today really focused on healthcare as a percent of GDP, and everything that you heard pretty much talked about the increase in healthcare costs, and virtually nothing that you heard talked about the increase in GDP in terms of healthcare technology increasing the rate of growth of GDP by making people more productive, making people have less absenteeism, less what the economists in the room might call presentism, which is you show up but you take a nap 2/3 of the time, or you're on eBay or whatever else you might do. And I think it's time for health economists to look at some of the technologies that we have that really improve the growth in the denominator, i.e. increase the rate of growth of GDP. And certainly that's what the latest round of RFPs from InHealth is really focused on. I think that we also talked a lot about the rate of rise of healthcare costs and the role of medical technology to ameliorate that rate of rise. In many regards, that really takes a more holistic view of the healthcare process. So it changes the site of care. We've seen a lot of that. Just look at minimally invasive surgeries over the last several years. In the area of kidney transplantation, which is, when I'm not doing this, what I actually know something about, is nephrology. Kidney donors, as altruistic an act as that was, you were in the hospital for a week to 10 days, and you basically were recuperating for 6 to 8 weeks, at an enormous cost to the economy, to yourself. Now you're in at least maybe 2 nights, but more often 1 night. You have 3 small incisions, and depending on how compulsive you are, you probably shouldn't go back to work for a week, but a lot of people go back before the week's over. And we all have, I mean, rare today is the person that gets their gallbladder taken out with anything other than minimally invasive surgery. Classic example of medical technology. And by the way, this was medical technology that was disseminated not through academic institutions, but by meeting the unmet medical needs of consumers and becoming widespread by the use of private practitioners who offered this service, if you will, and it was academia that had to sprint to catch up. Another example is robotic prostate surgery. The jury is somewhat out on that one. It appears that, or at least those people who support it, believe that you reduce the complications, which have both economic and psychologic complications for people undergoing radical prostate surgery. and we still are improving that technology. And as I said in some earlier remarks, I think that while I applaud the pioneers that submitted to surgery with version 1, if in the future I personally needed it, I would hope that we'd be up to version 7 and some of the bugs had been worked out. But again, this is something where the recuperative time is dramatically decreased. You can go back to becoming productive. I think those are some of the issues. Some of the things are going to wind up costing more money, and we need to identify those and do the kind of analysis, Steve, that you talked about with, probably don't like this phrase, but sort of a SWAT team approach, and show how even if it may increase costs in the numerator, it might increase the denominator even faster. So those would be the kinds of things that I would point to.